of the hypothalamic pituitary adrenal axis. So the major regulator starts from the CRF, which is the corticotropin releasing factor, which has got an effect along with AVP. Now this is important, and we talk about dual control. So the predominant control is in the hands of CRF, but vasopressin also has a control in terms of ACTH secretion. So there is alternate AVP ACTH cortisol axis. Remember, AVP increases ACTH, ACTH increases cortisol, and cortisol inhibits AVP. So this whole cycle is also working. So the ACTH comes into the picture, and this acts on its receptor, which is the melanocortin 2 receptor, the MC2 receptor, to produce cortisol in that regards. Now, CRF is basically a hypothalamic peptide, and it, like many of these peptides, is produced as a pre-pro compound. So we talked about pre-pro AVP. Similarly, you've got a pre-pro CRF, which is associated with a connecting peptide, and then you have got the CRF, which is released. It has got a very, very small half-life, and it is not really there in the blood. It doesn't need to be there. It will directly go and act on the pituitary. So that is why it's a local effect which is there. And when we talk about the hormone effect, we talked about that there is an amplification. As you go down the axis, the amount becomes more. So cortisol is in huge amount, nanomole or microgram or something. ACTH becomes picomoles, while CRF is even less. So that's how the importance. So higher the hierarchy, you've got one king of the jungle, and then you've got so many other small animals. So something like that, you can think that the biggest in the hierarchy will be the smallest in concentration, and systemic levels will not give you any important clue, so to speak, from that regards. Now, of course, these levels are suppressed via cortisol. So cortisol will suppress the hypothalamus, the pituitary, the adrenal, and that will be important from a glucocorticoid perspective. And this is produced via the paraventricular nucleus. Now, these are very common areas in which they are produced. Now, CRF and AVP both have an important interaction. They are produced on the supraoptic paraventricular nuclei, as I said, and then there is a connection with the pituitary stalk. Now, here we have got the production of CRF predominantly from the paraventricular nuclei, and AVP also is produced on the both sides. But the AVP from the supraoptic is predominantly controlling the osmotic one. The one which is produced in the paraventricular nuclei is controlling the adrenal. And there is a specific receptor also. We talked about AVP, there are specific receptors. The V2 receptor is predominantly acting at the and V2 is the predominant one for the renal concentration, the aquaporin one, and the V1. So V1A, V1B. So there are specific receptor phenotypes which are there to regulate the effect. So now CRF and AVP are taken from there, and through the hypothalamic hypophyseal system, they will go to the anterior pituitary, and there it will have an effect. Now, what does CRF does? So CRF is basically like a G protein coupled receptor. So it's like many of the other receptors like GHRH, GnRH, they are all G protein linked receptor, and it will basically bind to increase the G protein, causing a cyclic AMP production, which then triggers the POMC production. And we know from POMC everything comes out from that. Regards, AVP acts on the V1B receptor. That's what I was talking about. V2 receptor is the predominant receptor in the kidneys. V1B or V3, some people talk about V3 as well. It is there right in the corticotrophs, where it will act on the V1B, acting via the protein kinase C pathway. So there are two pathways which are regulating the ACTH production. And that's why if your AVP goes up, your ACTH goes up. Now, this has important implications in the management of CAH. In a patient, Dhwani, if they are treating with CAH, if you give less amount of mineralocorticoid, your glucocorticoid requirements go up. Why?
Then the child will go into hypotensive state.
So you will have hypovolemia. And hypovolemia will cause? Yes.
naturally of participants.
So AVP will go up. AVP will go up will basically mean the ACTH will go up and your 17-OHP will go up. So if you are underdosing your aldosterone, you would need to overdose your glucocorticoid, and that will cause growth retardation. So this is something very important. So if you need somebody who has a supraphysiological requirement of hydrocortisone, check your renin activity, whether you are good in terms of aldosterone replacement or not, and that becomes important from that regards. Now there is also effect of angiotensin 2. Now we remember that angiotensin 2 has got multiple effects. Angiotensin 2 basically is produced when you are in a very bad shape, when you are hypovolemic, you are less on fluid, you are less on sodium. So when you talk about angiotensin 2, what will it do to control all that? So you got less water, less sodium. So what will angiotensin 2 do? So that whatever water you have, your blood pressure becomes more. That is one. Number two, it increases thirst, so you take more water in. Third, that is very important because it wants your sodium to come up. And fourth, it increases AVP. It increases AVP so that you are not losing water in the urine. So single effect of ANG2 is going to give you more blood pressure via vasoconstriction, more free water via increasing thirst and decreasing AVP, increasing sodium absorption using the effect of the aldosterone. And of course, through this pathway, it is also going to affect the cortisol secretion as well. So in a way, when you are, this is like a distress signal. So if your ANG2 is going up, it is going to cause a lot of cascading effect on various other pathways from that regards. And ANP, the other one which we're talking about, the natriuretic peptide, is the opposite. ANP is basically produced when you've got too much fluid. So it will then inhibit your cortisol. It will then inhibit your AVP. It will inhibit your aldosterone. So the ANP and ANG2 are the opposite spectrum. So we have talked about the CRF axis. Now we will move more towards the ACTH part. So ACTH is basically produced as a pro-hormone, the pro-opiomelanocortin, which we discussed has got, of course, the name itself says opio, which means the opioids, mineralo. So opiomelano, which basically will mean pigmentation, and cortin means the cortisol secretion. So you've got the MSH, which is the melanocyte stimulating hormone. Then you have got the ACTH in that segment. And finally, you have got the endorphin and the LPH, which are the opioids. So these are the major products which come from the POMC pathway. From the splicing, you've got the MSH. Now, MSH acts on the MC4 receptor to cause pigmentation as well as satiety. Now, if you have a MC4 receptor defect, we all know that you will have a tall stature with obesity, with a lot of insulin resistance, and maybe pigmentation issues may be there. ACTH basically acts on the MC2 receptor to predominantly, and we'll talk about what it does, is to increase the cortisol production. There are various mechanisms by which it works, but it's mainly causing the cortisol production. Endorphins, of course, will result in a pain response. So if you have got a stress scenario and you're producing a lot of POMC, what are the benefits you will have? If you see, let's say, a tiger in front of you, your POMC goes up, what are the benefits you will have? Why is all this regulated together? Yes, so even if you are running, you will lose the pain and you will feel good. Your mood will become elevated and focused completely. So your opioid will come in, then your cortisol will go up. Your cortisol will go up, so your catecholamine activity will be maximally activity.
We don't feel hunger.
So you will say, I am happy, your satiety will be there, so you will forget about that. So often you will see that when you're giving examination or when, let's say, you're doing some competition, you're running or sports or something, you feel absolutely normal. In the rush of the thing, you don't feel anything. As soon as you come back home, you will feel that I'm tired, I'm having pain, I'm hungry. So all this is in a way numbed via POMC. So POMC is a primary factor in terms of your initial fight or flight, whatever response you want to fight the tiger, you want to run away, both cases, these hormones will become important from that perspective. Now, genetic regulation of corticotrophs, this we have discussed in more detail when we talk about the pituitary, but things which are relevant. So, of course, you can have multiple pituitary hormone deficiency involving ACTH using HESX1, LHX3/4, PITX1, PROP1. Now, whether POW1F1 will affect, Manoj? So, it's up till PROP1. So, PROP1 will cause MPHD. After that, you will have isolated ACTH deficiency. Isolated deficiencies are very, very uncommon in adrenal in terms of genetic causes. And predominantly, we have got the POMC defect. What will POMC defect cause?
The POMC defect cause multiple hormone
Like?
AVP.
Why? POMC. I'm not talking about proconvertase. POMC.
So there will be the obesity type 2 and obesity.
So obesity. So hyperphagia with obesity and ACTH deficiency.
Yes, ACTH deficiency.
And
there will be the hypopigmentation.
Depigmented hairs. So this is the classical triad of POMC defect. Proconvertase deficiency, which converts this POMC into different parts, will cause deficiency of AVP, ACTH, GnRH, along with insulin as well. So you will have diabetes, you will have obesity, you will have ACTH deficiency, which is there. So POMC is important. One of the isolated factors which is very common is TPIT, which plays also a role here, along with some other ones. This, when we talk about adrenal insufficiency, we'll talk about more detail. But remember, POMC and TPIT will be the major ones as far as the genetic regulation is concerned. And then, of course, you have got the DAX1 and the NR5A1, which I talked about initially, have an effect on adrenal development, cholesterol transport, and gonadotroph development. So that's why hypogonadotropic hypogonadism is linked with abnormalities in these perspectives, which we need to be aware about. Now, ACTH, as we discussed, is an important hormone. How is ACTH regulated? So major regulation of ACTH basically comes via CRF, so the major tone. So as we said, growth hormone, releasing hormone, growth hormone, TRH, TSH, dopamine, prolactin, GnRH, LSFSH. So CRF is the major tone setter, so to speak, and it's a tonic increase. The body increases the ACTH production. AVP also via the V1B receptor is having an effect. Cortisol, of course, will have an inhibitory effect. So cortisol inhibits the ACTH as well as the CRF receptor. At all levels, cortisol will inhibit, which is a feedback mechanism. It also inhibits AVP. Now, if you have an infection or if you have a stress hormone release, like interleukins, all this will also increase the production of cortisol, which is well known, and they will also have an ACTH effect. So based upon that, we'll start off with this case, 4-year-old boy with 21 hydroxylase deficiency. Dhwani, I think this is what we discussed recently. Hydrocort 18 milligram per meter square per day, a good dose. Fludrocortisone 0.05. He is reasonably okay in terms of height, slightly short. And what we are seeing is that his 17-OHP level is still high. So the treating physician says, okay, 17-OHP is high. I would like to increase the hydrocortisone dose, but you are concerned that the dose is already good. What do you think is going wrong in this case? So this is what we were discussing about, the interaction of aldosterone deficiency, hypovolemia, high AVP, high ACTH, high 17-OHP. So it's that long loop, which in simple terms we can say, if you are giving less mineralocorticoid, you will need more glucocorticoid. So as Dhwani has said, we would need to look at the PRA before we start to increase hydrocort, and this was high, indicating that we are discussing of a fludrocort deficiency in that scenario. So now, how does the ACTH act? So we talked about the CRF, which is basically a G protein coupled receptor. ACTH is also a G protein coupled receptor, and this is going to act via binding there. It is going to activate the G protein. Again, via the cyclic AMP pathway, is going to cause increased action of STAR, causing more cholesterol to go inside the mitochondria, causing production of steroid, and it's got other effects as well. Now, the receptor of ACTH is actually the MC2 receptor. Now, MC2 receptor is a special type of receptor, which is actually, so all receptors are actually produced within the cell, and then they have to be pushed out. And there is a specific receptor associated protein which pushes it out. Now, this MC2 receptor associated protein will then switch it towards the membrane. So if we talk about ACTH resistance, we are talking about two scenarios. One in which you have got no production of the ACTH receptor, or the second in which you have got the problem of the associated protein. So what is the difference in terms of manifestations on these two conditions, which we call as FGD1, familial glucocorticoid deficiency type 1, in which the ACTH receptor is not formed, MC2 receptor is not formed, and FGD2, in which you have a problem of the receptor associated protein. Vibha.
Sir, in receptor of this MRPA,
MRAP, yeah.
there will be false.
So very importantly, individuals who have got a problem of the MC2 receptor, they tend to be tall, cortisol deficiency, but MRAP do not cause tall stature because there are other effects as well of the MRAP pathway. Now, we know that ACTH is produced and ACTH is increasing cortisol. So what all does ACTH do in terms of increasing the cortisol? So how can you increase cortisol? Basically, you increase the supply. You increase the supply of the raw material. So the LDL goes up, your HMG-CoA goes up, so the internal production of steroid goes up. You will have got a greater activity of the star along with increase in the size of the adrenal cells. So your raw material becomes more, your raw material is pushed into your machines quicker, and your capacity also increases. So if you have ACTH excess, you have got large adrenals. What it means on the other way around is if you have ACTH deficiency, what will happen to the cortisol, to the adrenals?
So all the synthesis.
No, in terms of adrenal size.
It will increase, and then in the long-term deficiency, it will atrophy.
Yes. So if you have ACTH deficiency, let's say congenital deficiency, the adrenal size will be less, which will be smaller, but the adrenals will be formed. Similar to if you have a TSH receptor problem, you will have thyroid, but it will be very small. Same, you will have adrenal, but they will be very, very small from that perspective. Now, if you look at DAX1 defect will do what?
Will affect the all adrenal gonadal.
No, in terms of adrenal size.
So it will increase the.
So because of the regulation, the size will become much less. So that's why we talked about the AHC as a possibility. But in FGD, you will not have that much decrease in size, which is there. So it will cause increased size, increased vascularity. So more blood will come. So more cholesterol will come and increase enzyme activity. So there is a multitude of effect of ACTH on the adrenals. That is an important factor to consider. So now we have talked about the entire process, the hypothalamus. We talked about the CRF and how CRF and AVP control ACTH. ACTH controls cortisol from the MC2 receptor. So now this cortisol is going to inhibit ACTH. It also inhibits AVP, which we have already discussed earlier in that scenario. And if you have cortisol deficiency, you have SIADH, which happens. Cortisol also has an effect on CRF. Now, Dhwani, at what is the sequence in terms of suppression? Like which is suppressed first? So when I talk about pharmacotherapy, I'll say you have a suppression of the HPA axis. So which ones are the most sensitive for suppression and which one are going to be suppressed at the last moment when you're giving exogenous corticosteroids?
First thing to be suppressed
will be the hypothalamus,
yes.
Then the pituitary. Adrenal will be the last. So if you give very long-term therapy, your adrenals will become really atrophic. And then it becomes very difficult. It's going to take a long time in that perspective. So that is why duration and dose both become important. So if you give for less than 2 weeks, nothing is going to happen. Between 2 to 6 weeks, you may need to give alternative therapies. Beyond 6 weeks, suppression happens. Beyond 6 months, usually adrenal is also going to get involved. Now, adrenal involvement is largely because of ACTH deficiency. If you have no ACTH, your adrenal tonic effect will come down. So now in this scenario, Vibha, if you're doing an ACTH stimulation test, whether they will be more likely to be diagnosed with a high dose or a low dose test. Because if you give a high dose test, they may respond, because if there is remaining amount of adrenal tissue and there has been some ACTH exposure, you will have a normal scenario which is there in that perspective. Second question, if somebody has received long-term treatment with steroids, you have to give hydrocortisone. What about fludrocortisone? Because
there is a suppression of the ACTH excess, and the glucocorticoid is the renin
is not controlled by the ACTH. There's like 5 to 10% control, so it is not going to be affected from that regard. Now, any form of stress or fever where you have interleukins obviously also increases the stress hormone. Along with hypovolemia, they will increase ACTH. You can all go and have a look at our website, our courses which are available, and the mobile application. So